Good morning, everyone. My name is Dave Isley. I'm the director of the Department of Otolaryngology-Head and Neck Surgery here at Johns Hopkins, and I want to welcome everyone to the annual Michael Johns M.D. Lecture on Health Policy. We are fortunate in the Department of Otolaryngology to share this lectureship with the School of Medicine, and each year we have an outstanding speaker to focus on health policy. This lecture honors my predecessor in the department, Dr. Michael Johns, who was director of the Department of Otolaryngology-Head and Neck Surgery and then served as dean of the Johns Hopkins School of Medicine. For those celebrating your 30th year of graduation from the School of Medicine, he would have been your dean. He, after serving in that capacity, went on to Emory University and served in very high leadership positions, including board of the regents of Emory Healthcare and chancellor of Emory University. Mike, I know you're listening online, and we wish you were here with us, and we give you our regards. What I'd like to do now is introduce Dr. Dean DeWeese, who will introduce our annual speaker. Thank you.
Thank you, David. Good morning, everyone. Pleasure to see you all. Pleasure to be with you. And Mike, online, thank you for your continued support of this really important lecture. And to all the others, guests and alum who are online, welcome to you as well. It's a real pleasure for me, and really, frankly, a distinct honor to introduce our very special guest today, who will also be joining us online. He is a visionary leader that works at the intersections of medicine, technology, healthcare, to try to drive ultimately innovation that improves healthcare. And it's Dr. Nigam Shah. Dr. Shah is a professor of medicine at Stanford University and chief data scientist for Stanford Healthcare. And his research has, as I noted, been in this very important, interesting space, and I think more important every day, taking health data from electronic medical records, insurance claims, wearable technology, patient blogs, and how to put those together, synthesize those into answering questions about a given patient's health, populations of patients, how you build predictive models to ultimately help health systems and physicians improve healthcare for patients. At Stanford Healthcare, he oversees and is responsible for the responsible use of artificial intelligence to advance our understanding of disease and disease outcomes, of course, as well as how we deliver care. He's an award-winning teacher and has helped more than 5,000 students around the world through his AI and healthcare specialization that is on Coursera, I believe. Dr. Shah is a member and has been elected to the American College of Medical Informatics, and he was also inducted into the American Society of Clinical Investigation, into ASCI, as well as the Stanford Medical Leadership Program. He's published just a very few papers, I think around 350, and has helped to secure millions of dollars in federal research funding for the institution. And of course, his work not only has been in the medical sphere, but also in the more popular press of New York Times, Wall Street Journal, and many, many others. On top of all of that, and as you might guess from the kind of work that he's doing, he's been a very successful inventor of 9 separate patents and patent applications, has been an entrepreneur, co-founding 3 companies, and has raised over $100 million in capital for those companies. So with all of that, it's just a real pleasure and honor to have Dr. Nigam Shah today as the Johns Lecturer. Dr. Shah, I'll turn it over to you.
Well, thank you for the wonderful introduction, and thank you as well for giving us Lloyd Minor, who serves as our dean and enables all of the fun stuff the faculty here are able to accomplish. None of that would happen without, as you can imagine, with good leadership. I'm going to start sharing my slides. Hopefully, go up real quick. So I'm not a policy wonk. I try to do experiments that help policy experts make decisions. That's how I place myself. And today what I'll try and do is share with you this journey of how do we make sense of all of these data in order to do AI right. And, for those in the field, this isn't the first time AI has made big promises. This is actually the third. And hopefully this time we don't blow it as a community and not have another AI winter. So I'm pretty excited that so many people are interested in this for various reasons. So I'll jump straight in. Uh, Sorry, here. I'll share a little bit more context for where I'm coming from to contextualize what I'm going to share with you. The left half, the part in red, is my professor job. I call it my .edu persona, where it's the usual do research, write papers, get grants, a lot of teaching, both on campus and online. And on the right-hand side is my enterprise job or .org job, where I lead a team that's dedicated to bring our innovations on campus, not just from my lab, but from all the faculty, uh, into routine use safely, responsibly, and cost effectively. So, a lot of building, a lot of cross-functional leadership, and then I get shipped out on behalf of Stanford Healthcare to present. And then down below are my conflicts. Well, the two companies were already mentioned. And then the stuff below are my friends, and they call me, and so I have to disclose my advice to them. All right. So the most important thing I can share with you across all of these years of effort is to think of data in a timeline view. That is the most important thing that I can share. And what I have on screen here is an idealized view of a patient timeline. In this particular case, this individual had a couple of hospital admissions, which let's see if I can highlight them here. These are the hospital admissions. Sometimes they had 2 ICU admissions along the way. Um, and then below here are the different data types that we collect. And this example just shows a few, waveforms in the form of ECG, respiratory rate. We might have some numeric output, numbers like cardiac output and heart rate and vital signs and meds, progress notes, discharge summaries, and so on. Now, if we think about it, there's about 180 or so professional medical societies. Our campus has 123 residency and fellowship programs. Let's say we have 26 clinical departments, about 50 total clinical units, one way or the other, in terms of divisions inside of them and so on. And if we treat each and every one of them as a specialty, each specialty has their own favorite 5 or 10 things that they do. Every hole in the body, we can send a camera up and take videos or pictures. We can record electrical signals from 10 different places, EEGs, EKGs, EMGs inside the esophagus and whatnot. And so if we sort of collectively spend, 10 minutes just enumerating all the data types, I don't know, maybe we come up with 100, maybe 200 different data types that we like to collect. Genomic information, proteomic information, all sorts of exotic imaging, radiation therapy, chemotherapy information, videos while you're operating at the base of the skull. I mean, doctors have started collecting that. And then a couple of things remain true about this thing. So let's give it a name. Let's call this a patient timeline object. And in a practical setting, like Stanford Healthcare, we run about 1,300 IT systems. Let's say 400 of them are real, and some of their real platforms. And so these data from this 150 or so different modalities across 50 specialties is scattered across these 400 software systems. Epic is one of them. And that's just like when I started this role in the hospital a couple of years ago, like I knew the numbers, but it didn't like viscerally connect as to, oh my God, this one thing, this one patient timeline object is scattered across 50 specialties and 300 IT systems. And so what that leads to is if you look at any one modality, and then we have multiple health systems a patient goes to. So let's just say vitals. There is nobody who has a complete 5-year record of a person's vitals, for example. It's kind of strange, but no one person has it. And then at any given point in time, so if we look like in this vertical fashion, there is nobody that has collected everything there is to collect. And that makes sense. I mean, we don't do a biopsy and a colonoscopy and a chest MRI every time somebody shows up. We only collect what's needed. And so this patient timeline object, has a lot of holes. Some of them by choice, as in my record, you will not find a D-dimer or troponin C measurement. Well, that's because it was never needed. And in that case, that information or lack of information, that missingness actually means something. In other cases, it should have been present and it's not. And so we really have to think about the thinking that comes from missing information in the clinical trial setting and how we apply this to this observational setup. Anyway, so we have this patient timeline object. On our campus, we have it for about 4 million patients with all these caveats and holes that we just talked about. And then we use that to build models. So I'm going to put models in this little corner here, and we are not going to talk about models as much, but what we'll focus on is what do we do with those models? And these models could be logistic regression, deep neural networks, and there's textbooks and classes about those kinds of things. But at the end of the day, they produce a number. And we use that number to decide whether to treat somebody or how to treat them. Those, I would argue, are the two most important things we do in medicine. And in any given situation, multiple such concerns apply, which is what makes it complex. But at the base level, each decision is, all right, person has this, whether do I treat them? And then if I do, then how? Now, the whether to treat can be further broken down into a classification problem or a diagnosis problem in medical speak, or a prediction problem, which is a prognosis problem. The recommendation could be called decision or a treatment. And here we have to be a little bit careful about language, because often what happens is that we might say things like, we have a sepsis predictor. But there's no such thing as a sepsis predictor. It's a classifier. The thing tells us the patient has sepsis and we have not yet figured it out. And so in general language, we kind of abuse the word prediction. A lot of the things we do in medicine are really classification or diagnosis. There are a few true predictors as well, like predicting mortality or predicting 10-year risk of a heart attack and whatnot. And so we do these three things, and then the columns are, what are we doing these things in the service of? We can do all of this modeling to advance the science of medicine, the practice of medicine, clinical care, or the delivery of medical care to a large population, often called healthcare, or sometimes I call it the business of medicine. And it's really important to distinguish the two, and I'll spend a minute on an example. So let's just look at the first row, first column. So there's this disease called heart failure with preserved ejection fraction. Not top of mind for an otolaryngology audience, but cardiologists struggle with it quite a bit. And there were researchers at Northwestern, one of whom is now at Stanford, who found that this particular disease is actually 3 subtypes. And looking at genomic information, looking at cardiac output, EKGs, all sorts of things, metabolic profiles. So that's great. Now we know that there's a group of people who, if they get this disease, they're going to be fine for a decade. And there's some that might die in 2 years. That's an advance in the science of medicine in this classification exercise. Practice would advance, so we would jump over here if 2 more things happen, which is that patient walks in and I have a test. Could be a blood test, could be an AI test on the EKG or the ultrasound image or what have you. Like, I really don't care. I want to spend $1 in 5 minutes and know what subtype the patient has. And then I also need a treatment. For the people who are at risk of dying in 2 years, I need to be able to do something more for them. And for those that are going to be fine for a decade, we need to be able to back off and say our practice guidelines need to change and say, we're not going to do anything. It's okay. You'll be fine. So we need 2 things, a test and a treatment. The delivery would advance if we did this test and treat regime for 5 years or maybe 10 years, and people live longer or cost less or both. And so one of the reason I'm going into this much detail in this is that often what happens on academic medical campuses is that we see an advance in the science, and the next day a press release goes out saying practice solved or healthcare solved. And I'm sure all of you have those experiences. My first experience in that was when I joined my graduate programs and the human genome came out, and New York Times and Time Magazine and everybody promised that cancer was supposed to be cured in 10 years. And here we are. Um, so some good things do come out of it. That is what made me lead to my career switch. So it's not all bad. But the point here is that the incentives are different for each of these columns. People who are pushing the science, we seek to publish in Nature Science Cell. The pinnacle of achievement is a Nobel Prize. In the practice, we seek to publish in New England Journal, JAMA, Lancet, pinnacle of achievement, perhaps the Lasker Award. And then here, there's not much publication actually. We might write an article or two here and there in health affairs or places like that. But by and large, you measure success by, are your patients staying with you? Are they living longer? And is your clinical enterprise financially sustainable? So that's sort of my map of how to use modeling and do these activities of classification, prediction, recommendation to advance science practice or delivery. So look at two examples. So this is a project we did on our campus with original funding from the Emerson Collective and then the National Library of Medicine, where we took on a problem that has been a dream in medicine for 40, 50 plus years. And that is, at the bedside, if I have a question or an uncertain situation, can I answer what happened to other patients like mine? The first time a physician tried to do this was Dr. Alvin Feinstein using a computer at the New Haven VA, trying to answer what would happen to similar patients for a library of 684 lung cancer patients. And then various efforts in fits and starts. There was an effort at the Duke University for the Duke Data Bank for cardiology. Stanford did one for rheumatology called Artemis. Long story short, in 2016 or so, we put out a position piece saying, wouldn't it be nice if there was a button in the EHR that you press it and it told you what happened to other similar patients? Well, it turns out a button is a bad idea. We figured that out within a year. Even started my first company that went bankrupt doing that. And then internally, we said, all right, let's rethink how we're going to do this. Now, whenever something sufficiently complex comes in medicine, a new specialty takes care of it. And we had the clinical informatics specialty on our campus. And we said, how about we staff this just like we would staff radiology, pathology, emergency psychiatry, or what have you. So we set up an on-demand consultation service. And a doctor could call us and refer a case, and within a day, we'll provide a written report along with our interpretation of what we see in the aggregate data to what happened to other patients like mine. So we did a study funded by the National Library of Medicine, did about 100 cases, and the results were published in the New England Journal Catalyst. And so this is just a quick summary of the results. On the x-axis is the number of unique physicians who requested a consultation. Y-axis is the number of consultations. I'm in internal medicine, so that was the largest user. Oncology, cardiology, derm. We did at least one from every specialty. In fact, some of my otolaryngology colleagues were able to do such a consultation, expanded on larger data sets, and got JAMA papers doing that, Dr. Robson Capasso. One of the most important things here was for this service to not respond. So we did 100, we only responded to 83 consultations. 17 times we said the data can't help you here, not enough to give you a valid recommendation. And of the 83 we did, about 10 of them changed patient care. 52 of them led to some sort of research, ultimately leading to a publication. And 17 of them were like, yeah, the answer is not really fully sufficient. Can we do a follow-up analysis? Let's download the data, and we want to do it on our own under a separate IRB. So why does this matter? On the left is sort of one of the many pieces of evidence that are in support of why this matters. In this particular case, a group of physicians spent about a week making about 1,200 decisions, and then went back at a later date and said how many of them had any published evidence. And in their own reckoning, 80% of them had no basis in prior published data. It could be that they missed something and it was published and they didn't find it and all that. But if it's 80%, it's probably 50% that had nothing. And then less than 3% of the decisions were based on a study specific to the question at hand. And that also tracks, like common sense. If we do a back of the envelope, how many guidelines from in cardiology have level A evidence? It's about 19 to 20%. You ask a practicing doc, how often is it patient walks in and a guideline applies? 10 to 20% of the time. So 20% of evidence is level A, 20% of the time it applies, we're down to 4%. So most of the time, we're extrapolating based on what we have and making our best faith estimate. We record it in the EHR, in that patient timeline object, and we never go back. And so that's why this matters. It's a 50-year dream in medicine. On the right is when we finished the work, Lloyd Minor and our CEO David Entwistle sit me down and said, like, Nigam, how are we going to scale this? How do we make this work long term? I was thinking like a professor. I said, well, you can fund my lab for forever, and me and my 3 students will service the health system, for the foreseeable future. And they're like, no, that's not what we're talking about. How are we going to share it with the whole country? I was like, oh. So that's what led to Atropos Health, which is the image on the right-hand side, which is a spin-out that offers this now to Stanford and a whole bunch of other places. And that's all of the fundraising. All right, let's look at one more. Middle row, which is about making true predictions. And this time I'm going to go to the third column, which is about delivering care. So here we are making predictions about who is likely to die in the next 9 to 12 months. And there's a long story as to how we arrived at that. And that was resulting from after tenure, my department chair put me on a quality committee. And I was like, what have I done wrong? But in the end, we ended up talking about how it is the case that a lot of people should be getting advanced care planning and palliative care. And at that time, less than 1% were getting it. And I was like, this is not acceptable. And multiple humans were involved in this, so almost 40, 50 people. It's a very large project, which now has HIMSS Davis Awards and so on. But the point I want to make here is that building the model was the easy part. The prediction was easy. We built 3 models and they worked really great. It's this action that really matters. And so what I'm showing you on the plot here is over time, the number of unique patients that received advanced care planning, and the gray lines is the work that is done by physicians, and the red line is work that is done by all providers, so to speak. And what we're really proud of is this divergence at the end, where the workload on the physicians now is stable or declining, and the overall work is going up. And credit here goes to Dr. Winnie Tutberg and Stephanie Harmon in our department, where they created a serious illness conversation program and trained a lot of people, including respiratory workers, spiritual workers, respiratory therapists, spiritual workers, med students, fellows. Anyone can have the serious illness conversation. And now our rates hover at around 15%. And so tracking this action and building capacity for that, I think, is the crux of the work here. And so as we did those and other projects, like over the years, past 7 or 8 years, we've started to conceptualize them as this 3-pointed, star. There's the model, and of course, it's a lot of fun to build fancy models and deep neural nets and whatnot. But good AI-guided work happens if we focus on the policy. And this is not national policy, more of local policy in the sense that what is the number I need to see at which I will stand up and do something? And then the work capacity to do the thing that is necessary. And then the action, the thing you're going to do, like serious illness conversation planning, and what is the cost benefit trade-off of that particular action? So good AI-guided work or responsible AI is an intersection of all 3. And there's about 7 or 8 faculty that collectively work with me on this. It's about 35 or so papers that study this interplay. I'm going to distill it down to one plot. And that is this. It's a funny looking plot because I think we're the only ones who make it. On the x-axis is the rank order list of cases that you have estimated something on some probability of dying, probability of sepsis, probability of transfer, readmission, doesn't matter. On the y-axis is the cumulative utility, some benefit that you accrue as you successfully take action on one case or more cases. So we start out here at 0, and as we take action, we accrue some benefit. It keeps going, keeps going. You hit a maximum, and after that, you're kind of wasting effort, so you see diminishing returns. That's the intuition. The single most important thing that matters is how far down the list do you have capacity to go? And this is really important, and not enough thought gets paid to that. So, I'll give you sort of a cartoonish example. There's 10 specialists that want to build a model that shows an alert to the primary care doc to do something that's going to take 5 minutes for the primary care doctor to do something. So now in a 15-minute visit, this person could potentially see 10 alerts that require 15 minutes of work. Like, that's how absurd it gets. And we have to think it through in terms of the ripple effects that one department's behavior has on the overall system of care. And do we have the work capacity to sustain that? Like, that is the most important thing. What can you achieve given work capacity? Otherwise, your model is not going to have any effect. So we call all of this our framework for evaluating fair, useful, reliable models, or FIRM in our health system. If you search for firm.stanford.edu, you'll find more details on it. And so this is what is the essence of it under the hood. About 10 steps. In the first step, say, what are we doing? Why are we doing it? Step 2 is more of the engineering side. And step 3 is like, how are we going to prospectively evaluate whether the deployed system had the intended impact? Basically, that is, are we sustaining the work, and are we getting the output that we anticipated? We have to do that assessment prospectively and honestly. We also did something where we look at ethical considerations up front before we write the first line of code. And this is work by Michelle Mello and Danton Char, where the intuition is, can we interview stakeholders and find value collisions up front? Because that is where things go south. And then we also do financial projections, because these actions, these workflows need to be financially sustainable. Can we do that year over year and not just stop after doing a pilot project? So those are the two things which I think are unique on our campus. We do them up front before we even launch anything in the healthcare system. All of that, so that firm assessment is this yellow box here, is packed inside of what I call the dance of healthcare, or the dance of governance, rather. Our name for that is Responsible AI Lifecycle. And the point here is that any organization will have some, basic rhythms. In our case, we sort of broke them up into, I don't know what's going on here. It's jumping around. In 4 parts, there are people at the front lines who are the operations people, facing the patients, checking them in, delivering care. Then there's your IT staff that is usually behind the scenes. The patient never sees them. Then there's the governance, the C-suite and department chairs and so on. And then there's your data science team or AI team or whatever you call it. Sometimes it's separate. In our case, it's actually embedded inside of IT, but we just break it out here for simplicity. And so what this workflow is essentially, what is the rules of engagement and the dance and handoff between all of these different constituents? Who receives the input? Who assesses it? Who's going to do this kind of evaluation? Should we do it? This committee is probably the most important thing. We call it a data science executive committee. And they look at the ethical issues, the financial projections, total resource requirement, work capacity, and decide yes or no. And the point is, if they say no, it comes from the CEO and the dean together. So usually there's no other higher power that can override them. And then if we say yes, we also put in place monitoring before we actually deploy anything in practice. So this interplay, like, it's a fancy PowerPoint slide, like no big deal there. But figuring out that organizational rhythm is essential infrastructure for an organization to execute properly. So all of this is sort of wrapped up into this data science team that I lead. Um, we have a pillar on thought leadership and making sure that we stay at the front in figuring out how to do things responsibly. We do these assessments, these form assessments. We've done 26 in the past 2 years. We have another 10 in queue right now. We aim for a 6 to 8 week turnaround. The processes, that's this diagram here, and then infrastructure that's not shown here, Databricks, your Azure Compute, or what have you, so that you are AI ready as an organization. And then last but not least is to identify and execute 3 to 5 projects that have huge enterprise value. Because otherwise we can't sustain any of this. We have to make sure this is a repeatable process. So all of this, I started this job in March 2022. We thought we had all this figured out in 6 months. And then along came large language models. November 2022 is when ChatGPT got released. GPT had been around prior to that. We'd been tracking things in that since 2019. Our first published paper is in January 2021. But it was a niche thing. It was like, 500 people cared. And then when ChatGPT came around, like suddenly 100 million people started caring. Like, what the heck? How are we going to keep up with this? And so before we sort of dive into the LLM side of the house, I want to go back to the timeline. So language models, by now everybody knows that the general high-level conception is like you're predicting the next word or the next token. I am, on, my, and way, like everybody knows that. And there's all sorts of nuances. Are you predicting the next word, next 500 words, and what are you hiding, and so on. But at a very intuitive level, it's about predicting the next token. And I put language in quotes here because when we say language, for most people, it's natural language, like English, Spanish, German, Gujarati, what have you. But this sequence of tokens is a language, just like the sequence of DNA is a language. The sequence of amino acids is a language. And our language, I don't know why this jumps around, has these kinds of codes: visits, CPT codes, ICD codes, prescription codes, and so on. If we pause for a second and say, all right, how about instead of focusing on the copy-pasted language in our documents, we look at the sequence of tokens, just like we would look at a sequence of amino acids. What can we do using the technology of language models, but feeding it another language? And so that gives us 2 ways to think about this. The top in blue is the traditional way of thinking about it. We're feeding documents, and we build a language model, and we can do chat and summarization, so to speak. And that is where 95% of the world is focused on. On the bottom in red is we feed these timelines, these tokens that are the codes from our personal vocabulary of healthcare. Then we can forecast what's going to happen. Just like you can predict the next word, you can predict the next event. And all of this is summarized at this URL below. We did a lit review and found that a lot of stuff was in the blue, but masquerading as what's in the red. But I'll show you a concrete example. If we build such timeline trained models, what do we get? So on screen here is a plot where on the x-axis is the number of examples I have to train a classifier or a predictor. Y-axis is performance, and the red, orange, and light blue lines are all the standard methods: gradient boosted models, logistic regressions, random forests. The point I want you to focus on is here. The dark blue is the timeline trained language model. Language in quotes, because there's no human readable natural language there. And we can hit performance as good or better than all of these other methods by looking at just 128 positive examples. That is game changing. Now you show me 128 examples, I can create a classifier. So we now have a partnership with the Chan Zuckerberg Institute to see, can we build classifiers that identify patients who have undiagnosed rare diseases? Because we don't have that much training data. We don't have enough labeled data to use the same techniques as building a sepsis classifier or readmissions predictor. Other benefits, of course, you get higher accuracy between 3 to 19%, trains 8 times faster, you need 95% less training data. Now, don't take my word for it. The two links below are where you can download the data sets and the code and reproduce this plot to convince yourself that, yes, this indeed works. But we don't pay much attention to this EHR language or medical language. We're mostly doing the stuff in the blue. So we took a look at what are people doing with that regular language models. And so this is a JAMA paper on testing and evaluations of applications of what we typically call large language models, where language is English, Spanish, German, natural language. So the plot here, we asked 5 questions in this paper. Question 1 was, are you using EHR data or something else? Question 2 was, what is the healthcare task you're doing? Question 3, what is the language task you're doing? Question 4 is, what is the metric of evaluation? And question 5 is, what medical specialty? About 519 papers were reviewed. Turns out 95% of them were basing their conclusions not on EHR data. Amongst the most cited paper is about responding to patient messages and those responses being deemed more empathetic by patients. Turns out if you look into the paper, the messages are from Reddit, no patients were involved, and the people who are doing the judgment of the patients will like this are doctors themselves, like it wasn't patients. Only 5% of papers were testing with real EHR data. And then the majority of the task was what we euphemistically call enhancing medical knowledge, asking USMLE type exam questions, 222 papers. And of course, question answering is the biggest thing from a language standpoint. We love accuracy, maybe comprehensiveness, and factuality, robustness, calibration, uncertainty are kind of ignored. The few ones below here are all interesting and actually valuable, making diagnoses, educating patients, treatment recommendations, communicating with patients, care coordination, triage. These are the things that are of high value in a health system as opposed to just answering medical questions. But again, people do this because it's easy, because you can, and so on. So we said, all right, what can I do better? What can we do better in evaluation? So we said, let's verify the benefits of these off-the-shelf LLMs. So on the left is a plot where we fed some of the questions from that first project, the Green Button project, to GPT 3.5 and 4. 3.5 is the left pillar, 4 is the rightmost pillar. And then we showed the answers to clinicians, 12 clinicians, and said, does the answer agree with prior information or prior reference answer we have? I'm not going to call it truth. Does it disagree, or you can't assess? And the good news, from 3.5 to 4, agreement is up, disagreement is down, unable to assess is down. Great news, massive progress in technology. But about half the time, the 12 physicians had no majority in what was the case. That's like having something at the bedside, or somebody at the bedside, who answers very confidently, and half the time you can tell whether it's right or wrong. So by now, everybody knows this. Passing exams does not mean that it's useful. Then we said, okay, we want to use these things to do medical summaries, respond to patients, and so on. So we started giving prompts from physicians, like summarize from the EHR, the strokes the patient had, and their associated neurologic deficits. We then provide the real EHR of the patient. The language model writes a response, the physician also writes a response, and then we compare. That was the Med-Align project. 35% error rate when we did that study. So okay. So we thought we would now have to expand this into a much larger effort for evaluating LLMs for healthcare tasks. So this project is called MedHelm. If you search for MedHelm Stanford, you'll find it. The paper is going on archive any day now. And what we did was we said, all right, let's first make a list of tasks we want to do. So this particular list, in the example, it's only showing about 25 or so rows. We have about 121 tasks grouped into categories and subcategories. And then for every subcategory, we found a data set that has real EHR data and a metric by which we can evaluate a language model provided answer. In some cases, exact match, some cases, BERT score. We have started now using LLM as a judge in the most recent version of this. And then using those data sets, each of which have a true patient context, a prompt that model is supposed to accomplish, a reference answer, and a metric by which I can evaluate a model's answer. We just evaluated 6 models in this particular first pass. And you can see it's like there's no clear winner here. There are some models that are good at some things and they fail at others. And open source is not as bad, actually, the third column. And so a new version of this is just going out with a few more rows, 9 models, including reasoning models, and the DeepSeek models map out to be surprisingly good, and they're free. So that's something worth paying attention to. So the point here on the language model side of the house is that we really need to focus on defining and verifying benefits. We can't fall into the same trap of let's just build yet another model, or let's just take a public data set and claim that we're 99% accurate. We really have to verify benefits, and we have to deploy them responsibly. For example, I'm sure Hopkins also has this. Everybody went in deploying large language models to respond to patient messages, believing it's going to save us time. And it didn't. We adopted ambient scribe technology, again with time savings, and study after study is showing they're not really saving time. We got lucky, though, that it does reduce physician burnout and cognitive workload, so that's great. We literally got lucky that we had the side effect that was not anticipated. But there are health systems out there, and amongst the CMOs, this is a hot topic, that are asking their physicians that if you want ambient AI scribing, you have to see a few more patients. That, in my books, is not responsible deployment. We're thinking about this wrong. And so we upfront have to pay a lot of attention on specifying and verifying the benefits before we adopt this technology. And this is in a special communication in JAMA. All right, so to wrap up, like, how do I think about this space? I think it's a very fast-moving space. On the technology front, we really have to think multimodal. So this is just a smaller version of that patient timeline. Typically, people who work with images just work with images. People who work with EHR data or the streaming data for, say, whatever prediction, they work with their electrical signals. We really need to connect these two. And not just these two, we need to connect everything. Multimodal. And as we connect that, we have to look over time. We nearly need to get into true prediction. So we need to use what I call labels from the future in order to figure out what to do today. And we've done some of the work in that. The title of that work is MOTOR, M-O-T-O-R. And then there's some work where we take labels from the future, outcome labels, and train an imaging model today to predict that outcome 6 months out, 5 years out, and so on, instead of just using concurrent labels. So that's on the technology front, I think, what we need to be doing. On the policy front, I think we really need to redefine value. I'm just going to focus on productivity just to give a very dramatic example. So let's say we're using ambient scribes. The number of patients seen is the same, so output is the same. Input is higher. We still pay physician salary, and now we have to buy the software. So with simple math, constant output, larger input, productivity went down. And so the C-suite then goes back saying, hey, doc, you got to see 2 more patients because we define productivity as increasing throughput of care delivery. I don't think that's going to work. We have to think differently. So the analogy I use is, do washing machines save time? Like, they don't. We just get cleaner clothes. So if we only value saving time, it's not going to pan out. We do have to value cleaner clothes too. And so same thing, we have to think a little bit differently about how we think of value of using these technologies. The third big bucket is what's the best setup of use? Everybody rushes to say human in the loop. And I think that's another nonsensical approach for a couple of reasons. What are we keeping the human in the loop for? Is it as an overwatch or a failsafe? So on screen I have is this cell counter thing that we used when I trained. We would make a blood smear and then count how many basophils and monocytes and neutrophils of different kinds we're seeing. Today, this is done by a cell sorter. You put blood in, out comes the CBC. Nobody asks the pathologist to manually verify the CBC's output. Why do we ask the radiologist to verify the read of the image, or the pathologist to verify the read of the pathology slide? Like, why are we keeping human in the loop? Study after study there is also showing that by keeping human in the loop, often you slow them down or you increase their cognitive burden because they're always on edge. Are we just doing this as a receptacle for liability? Maybe there's an easy cop out to say human in the loop. Hey doc, you hold liability. Me, producer of the AI, assumes no liability. And then there's some very interesting study coming out. Some of work is from Jonathan Chenin at Stanford. This particular plot is from Google, that maybe humans are just impediments to AI. So what this plot is showing is diagnostic accuracy of this system by Google called AMI, and is your correct diagnosis in the top N. And as you can see, at all levels of performance, the automated system only is better than the clinician assisted by the system, which is in orange here. So what does that tell us? Should we keep the human out of the loop so that it doesn't mess up the AI? I think we really need to pay attention into how this is all going to come together. The cop answer of human in the loop for oversight, I don't think holds water. And then I'll close out with maybe we need to think about this differently. So this is from Erik Brynjolfsson here at our Human-Centered AI Institute. Everyone probably knows about the Turing test, where a computer passes off as being a human. This is the Turing trap, where a human only imagines using a computer for tasks that we already know how to do. I know how to respond to a patient message, so that's what I'm going to use a computer to do. I know how to read a CBC, so I'll use a computer to do that. And I know how to read an X-ray, so I'm going to use a computer to do that. But what about here? That's what I would encourage all of you to think about. No human can remember 1 million cases. The Green Button Project can. That's a new task that humans can do with the help of machines. We cannot do this unaided. So that's how I would encourage us thinking about this. And then to bring it all together, responsible AI in health systems, here's standard, here's generative. Call them whatever 3 steps, 1, 2, 3, discovery, development, dissemination. I think the key thing is what's the readout we aim for? And it should be around specifying and verifying the benefit at that point or that stage. At the first stage, it's feasibility and acceptance. Second stage, are you meeting the intent? And then third, we will have to change the way we do business in order to get the benefits that we aspire to achieve. On the standard AI, we have a mature worldview here. That's the firm. And then here, we're still figuring it out. MedHelm is sort of our first step there. And I'll pause here and happily take questions. I see one question already, which is about can we get the links again for the data sets? Of course, right here.
Great. Dr. Shah, that was fantastic, by the way, for those of us who've been thinking about this in not nearly as sophisticated a manner as you have. We worked on our first thing back in 2004, and you touched on the things that I could conceive, but I had no way to get there. And so our teams have been making iterative progress, and I think you have shown that it can be done. It takes a lot of foresight and rigorous thinking to get us there. So thank you for that. So I'll take some questions from the audience too, if anyone has any. If not, you sort of alluded to this, but I'd love to just maybe have you drill down a moment more. So where we are today, do you think we'll get to a place where a general, let me call it general chat GPT, is that better, worse, the same as, or do you require a medical specific GPT and a law specific GPT and an architecture specific GPT? And this may be very naive, I was considering that, is a liberal education thought to help inform the way we all make decisions because you're gathering a lot of education from a broad source of literature and art and history, et cetera, et cetera. And so maybe your decisions are more complete? Or are you just sending someone in from high school right to medical school and working on that? That is very simplistic, I realize, but I'd love to have your opinion about that.
So sort of a fun answer and then a more thoughtful answer. The fun answer is I went to med school right after high school. So it turned out okay for me. I think the question presupposes that the only way to think of technology is displacement of existing work. And I would sort of go back to this Turing trap way of thinking about it. Like the way health systems are currently organized and the way they are is because of the incentives and the supply and demand structures that we have. Or this new technology fundamentally changes things. And so the way I would answer the question is, now that we have the ability to have a 24/7 assistant be my sidekick, and if I was a country doc and and launching my new GP practice, how would I organize it? And I'll use an example from dermatology. So right now, a lot of AI being sold in derm is about, I'm going to look at an image and help the dermatologist make the diagnosis. Like, does the dermatologist even need that help? Like, that's a different question.
Right.
But if I'm a new dermatologist and the current way practice is organized, I go to a physical location and I see patients and I see maybe 10 patients a day, 60-70% of them tend to be normal, nothing wrong with them, maybe half of them. So what about I create an AI that is the first point of contact. And if the app says you're normal, you're normal. I don't need to see the patient. Now, if we set up things that we would build the AI differently, it would not try to diagnose the 10,000 things that a human can. It will only do one thing. Like, do you need to see the human or not? So do triage. If I do triage in that manner, maybe a single dermatologist can now service 20,000 people. We solve access and capacity. So I think that's the way I would like. We need to think differently. Like this Turing trap thing is sort of the most provocative slide I've seen in a long time. That would we organize our business the same way if we had these technologies when we started the business?
Yeah, I really appreciate that response because I do think we'll never train enough, at least the way we are envisioning it. We're never going to train enough physicians or other providers to solve our access issues, neither on a local level or in the country or certainly around the world. So I think you hit it exactly on the head. I have a couple other questions, but I'd love to just make sure the audience. Yes, sir. And I'll repeat it too.
There's questions online as well.
So, Dr. Shah, the question, I'll paraphrase, was how do we or should we be training physicians differently today with this as a backdrop of a part of the tools going forward? And in particular, how would we orient their training to the places where the technology isn't capable, or at least today isn't capable of supporting us? Thoughts?
Yes, we definitely need to rethink the way we manufacture MDs and train our people. Like 100%, no doubt about it. The question there is, what are we going to drop from the curriculum?
Yeah.
We can't keep just stuffing it more things in. And when my father's elder brother went to med school, and we all went to med school 25 years apart at the same med school, which is kind of funny. And his textbook of physiology was like this much, and dad's was this much, and mine was this big. I was like, okay. And it was all still 4.5 years.
Yeah, it is not an easy question to answer, but you're right. And we've been struggling with that each year in our senior curriculum of what is it that we rotate in and out.
Yep.
Which is, and the fact is, that's been true before. Things get left by the side. We don't tend to think about them. But this is a gigantic paradigm shift, as Dr. Shah has been saying. That's a more complicated one for us to understand. At least it is for us.
I think it's for everybody, but we have to tackle this one head on because the alternative is chaos.
Yeah.
And and it does require a lot of disciplined thought because it's a prioritization exercise. Like, what matters now? Like, do I really need to force everybody to know all the anatomy if all they're going to do is operate in the head and neck region?
I think I would agree with that. I think, and it is it's a matter of how much mastery does one need early on.
Yep.
Because we all know, indeed, we do lose mastery over time of various things that we learned.
Yep.
That was
how many people in the audience? How many people in the audience can draw out a Krebs cycle right now?
Yeah. But that was almost my point in their first part. If the liberal arts, quote unquote, education was all of the stuff we learned, as an oncologist, am I better because I happen to either remember or vaguely remember various portions of other parts of my medical training, such that when I see something odd or interesting, I'm better? I first, before I grab your question, I cannot see up here any of the questions online.
Yeah, there's one online that I think is worth taking.
Why don't you go ahead with that, and then I'll come to our audience member.
Yeah, it's by Dr. Bruce Taylor. Please comment if you can on the benefit of universal secure electronic health records, like everything, records, insurance, payments, and so on. This is technology needed for universal healthcare, but could be implemented in the US without universal healthcare. And seems that applying AI on a large scale of all patients who agree to participate would immensely improve our ability to do research as well as care. 100%. In fact, I'm a huge fan of one of your faculty, Ruth Faden, who argued many years ago, almost a decade plus ago now, saying, if I want to benefit from the data of the collective care of others, is it not my moral duty to share my own data? I think that's a very powerful statement. The US is amongst the few countries where you ask people, do you want your care to benefit from other people's care? Everybody's hands goes up. And then you say, will you share your data? And they say, no, I want my data to be private. I was like, that doesn't work.
Yeah. Sir.
I'm concerned about the changes that would have to occur in the doctor-patient relationship. You'd have to train the patient to be more trusting of large data systems and less interaction with the physician. And you also have to train the physician to be more reliant on large data and less personal capacity with the patient. How is that going to change medicine?
So great question. The patients are already training themselves. The number of people whose first response to anything is a Google search or now a Perplexity search or what have you is rising very fast. I think it is the training the physicians that is within our control. And I think we already have the necessary medical specialty, clinical informatics. And right now we take those graduates and have them babysit Epic, as I say. I think like, well, how useful would it be if the radiologist just ran the MRI scanners? So we need to delegate that kind of work to technicians so that the physicians can really expand the scope of this new specialty, call it whatever, better decisions from data, data-driven medicine, data science in medicine, clinical informatics. Like, the label doesn't matter, but we need people who can interpret large data sets and then write a report just like a pathologist or radiologist does.
Do you think that in the example that you gave of the dermatologist and just the screening that could be done and your use of Google, do you see involving a physician at that point? Because as a patient, I'll go to Google and then I'll take that information to the physician and perhaps challenge the physician. But the way the dermatology example would be, would you see the patient saying to whatever the system is, here, examine me, do this screening, a skin screening exam, and then if it comes out negative or positive, then I would go to the dermatologist.
Yeah. So yes, I view that as a scope of practice question. As these tools get better and better, we can start delegating more things to, quote unquote, the bot. Start out simple with no authority, and then we start doing experiments prospectively, saying, all right, if we allow it to make decisions about two things, how does that change care? So we really need to implement that rapid cycle experimentation, which again has been championed as learning health system and other names many times over. Now is the time that if we don't start that properly, we're just going to get overrun by this technology and other people will make decisions for us. And for the physicians in the audience, the last time we sat out a massive technology revolution, we got EHRs.
Yeah. With that positive, Peter, just one quick question. We're running out of time.
Okay, just one question. This is a mess. For example, I saw this patient that had essentially an adenocarcinoma of unknown primary metastatic to his pancreas, but the systems, Epic and so forth, require a diagnosis. We entered the diagnosis of pancreatic cancer because that's one of the organs that was suggested as primary. So he failed his treatment for that, the initial treatment, but pathologically this could have originated in the stomach, the esophagus. The computer system is totally unable to recognize this. The insurance company uses that to deny the diagnosis of pancreatic cancer, to deny him other treatments that would have been useful for gastric or esophagogastric. So it required a human-to-human interaction to have this overridden. And I just wonder, it seems like this is a tremendous waste of time when you get these machines that cannot recognize the subtleties. I wonder what your comment is on that.
Yeah, no, this is a great example. Like, one of our ethicists, Danton Carr, says, we're having bot versus bot warfare mediated by humans now, which is exactly what the situation you're describing. And I think that arises because of the way we conceptualize the use of these tools. We're putting them with a human in the loop, but with a very short view, very narrow tunnel vision view. The eligibility for care decisions used to be done by a human, and we automated them into a bunch of rules in software sold by an insurance company. And then we kind of poured concrete on it saying, you got to follow this, no judgment allowed. So I think this is a breakdown in the conceptualization of how we work with the technology. It's a great example of falling into the Turing trap and then just trapping ourselves in it.
Thank you.
Thank you.
Nigam, thank you very much. This was fantastically done. real asset to not just Stanford, but obviously to all of medicine. And your leadership is going to help us find our way forward. So, ladies and gentlemen, please join me in thanking Dr. Shah.
Thank you. Thanks for having me.
And we'll be sending you a gift of appreciation in the mail soon. So thanks again,
Thank you.
everybody. Thank you, Nigam.
Thank
God
you.
bless. Bye-bye.
Bye.